Hello and welcome to another episode of the Your AKT Podcast, which is hosted by WellMedic.co.uk. In this scenario, we're going to focus on blood results, and we're going to do that for the next scenario as well. So you have reviewed an elderly female who presented with generalized fatigue, and your routine bloods that you ordered have revealed a mild hypercalcaemia of 2.81 with a low vitamin D of 24. The patient is otherwise fit and well, and all of her other bloods are completely normal. You decide to repeat the Braun profile, which remains elevated with a raised PTH at this point. What is the likely diagnosis? So this question is obviously very tricky, but it's really important because the major cause or most common cause for a mild hypercalcemia in primary care is primary hyperparathyroidism. So before we break down the bloods, let's just consider how the parathyroid hormone works, because actually this is really important in demonstrating what's going on. So parathyroid hormone, PTH, is primarily involved in maintaining calcium homeostasis. So it can help resorb calcium from our bones, from our kidneys, and it also has a function of activating vitamin D within the kidneys so that we can then absorb calcium from within our gut. Now, the way that I think of primary hyperparathyroidism or primary parathyroid disorders is that the problem is present within the gland itself. So that's primary. Whereas with secondary and tertiary problems, the problems are ultimately caused by low calcium. So what causes low calcium? Well, vitamin D deficiency causes low calcium, or a renal failure would cause low calcium. And then the body has to respond to that. And as a result of that, your parathyroid hormone has to work harder. So in primary hyperparathyroidism, we would expect high calcium levels with high or normal to high parathyroid hormone. Secondary hyperparathyroidism occurs when the calcium is low. Okay, and we would then expect the PTH levels to increase to try and bridge that gap. So what it's trying to do is respond to bring the calcium back into range. And then tertiary hyperparathyroidism is very much an extension of secondary hyperparathyroidism. But this is where the parathyroid gland is now in overdrive, so it's having to work really, really hard, so it continues to pump out PTH, and then it elevates to calcium, so you then end up with a raised PTH and a raised calcium, and possibly some reasons for having a low calcium, such as either vitamin D deficiency or renal failure. So in this scenario, in our lady, where we've got a mild hypercalcemia, where we've got a raised PTH, it's either going to be either primary hyperparathyroidism or it's going to be tertiary hyperparathyroidism. So if you'd like to know more about managing borderline calcium levels, especially if there's a normal to high PTH, then I would highly recommend that you look at NICE, because they have a great visual summary for hyperparathyroidism. And of course, this is a monstrous topic. It's really difficult. But the aim is really to highlight how some of the scenarios may appear within your AKT and the types of resources that you may want to use to broaden your understanding as well. Now, if you want to know more about what I think about the different resources for the AKT exam, you can check out our premium course at wellmedic.co.uk. But I would highly suggest that you do share these scenarios with your peers so that they can get full benefit of the topics that we're discussing as well. Thank you so much for listening. I'll join you in the next scenario. This podcast is hosted by WellMedic.co.uk. We help GP trainees pass the AKT.